Bill, here is, as Jeffrey would say, Marsha, Marsha, Marsha.
Oh,
uh,
I'm going to fly in next year just to get you back for that.
okay. All right, you're up, Marsha. Go for it.
Okay. Thank you. Thank you. Thank you for letting me participate. And I'm thrilled to be here, even though I'm not there. God willing, next year I'll get there. Okay. So this year I'm talking about vision habilitation. And habilitation is a lot different from rehabilitation. And there are some medical legal definitions of habilitation and rehabilitation. And one of the reasons why it's important to understand which you're doing is because many states have a law that requires insurance to pay for habilitative therapies. And that's an issue that when I was there working, we all ran into problems with that. So you're more likely to be doing habilitative therapy with young children. You're more likely to be doing rehabilitative therapy with someone who is older, who has lost visual skills. And this is going to be something that potentially can be addressed with different state legislatures. It's worth finding out what your state has. Okay, so in no particular order, because I do habilitative therapy here as well as rehabilitative therapy, even though I'm retired. So I made a list of a lot of different components of vision. And this isn't everything. I have no doubt that other people can come up with things that I have missed. But every single one of these is a necessary property of vision to get to have visually guided behaviors, to have visually guided cognitive constructs. Now, this I took out of a non-optometric source because in looking at vision habilitation, I wanted to find out what do other professionals who are doing this, because there are a lot of schools and programs for visually impaired children, what do they mean when they talk about vision and vision habilitation and vision rehabilitation? So this is the way they describe the process of sight, which is their definition of vision. So all of the things that we do, that we expect our patients to have certain skills, they're kind of missing in here, with the exception of reflex focusing. So I looked at some of the non-optometric theories about how infants learn to see, and I came up with two basic theories that I'll share here. This one starts out initially, the organization of the visual system is just chaotic. The neurons fire randomly, they're unstable patterns. They feel that motion is truly critical. And after birth, that's when you get most of the input. And what they're saying here is that there are objects in your field that move together, we perceive them as one object. Interesting concept. Then they talk about neural alignment and stability, repeated exposures, and then they talk about building representations and how do we experience shapes. And this is how we build repetitive learning into the system. So they talk about neuroplasticity, which we all know kind of ends after early childhood. But this is one of the main theories, and I found this in a lot of information through NIH. Then there's also a module theory of vision, and these two seem to be the most referred to when we talk about vision habilitation. In this theory, there's a very early mismatch, which is similar to the chaos concept. After visual input repetitively, the neurons start to align, we form modules and we get stabilized visual responses, and they call it a learning boost. And I got a little confused about this, but basically they feel they are pre-wired, that it's all basically hardwired. We just need to connect all of the pieces, that there's not a whole lot of learning in there. It's all just about connecting the parts of the visual system that are pre-wired neurologically. Now they cite some evidence that they find, and they also conclude that for learning to occur, visual information received by the modules has to increase in reliability. And the information coming into the modules must become better aligned with the connections between those modules. So we're again talking about a certain amount of afferent feedback and repetition, but they say it a lot differently. The brain learns to see through a dynamic process where early visual experiences, especially motion, stimulates the alignment of neural circuits. It stimulates the growth of robust neural circuits. We get stable object representations. We shift from chaotic signals to organized patterns. From there, we start to get perception, memory, and visual learning. And motion is a significant concept in all of the theories of visual learning, because they're using this to both for motion of objects in the patient's visual field and motion of the subject, him or herself. So at least they're talking about the importance of motion, but nowhere does anyone really seem to be talking about development of ocular motor skills. So either we're kind of hardwired for ocular motor skills to develop, or we're not. Either they develop normally or they don't. And I did have a problem with some of this, because right now, a lot of what I'm doing involves working with severely visually impaired children and teaching them how to see. Now, this is an interesting book. If you're not familiar with it, it's a very, very quick read. It's available for free as an EPUB. It's worthwhile because this is used as a textbook in many countries for teaching teachers of visually impaired children. So this will give you the basis of how teachers are looking at visually impaired children and how academic support is shaped. Now, there's a lot of discussion in the book, and also in terms of what we do professionally, between cortical visual impairment and cerebral visual impairment. They're not the same thing. Generally, when they talk about CVI, they're talking about cortical visual impairment, and cerebral visual impairment is considered more of an agnosia. They differentiate based on brain damage, and yet you're not going to get a lot of agnosias without brain damage either. So I also saw the term neurological visual impairment, which is more inclusive, but to my knowledge in the US, at least it wasn't when I left, it wasn't an acceptable medical legal term yet. Now, they say it's difficult to recognize CVI, but I think it's something that we are exceptionally well equipped to do. We can identify the visual impairments in children. We can identify the components of the impairments, and there's a lot we can do to start rehabilitating that, or when we're working with kids, and I have to correct how I say this, habilitate them. So CVI, cortical visual impairment, they're saying it's a disability of access to the visual world. And this is something we see in our patients. Their visual impairments, however we've diagnosed them, in some way limit their access to the visual world. So there are teachers out there and therapists out there who understand the concepts by which we are approaching vision therapy and what we're trying to accomplish. And they understand that there's a difference between CVI and total blindness. And they understand that when you have problems with how vision is processed in the brain, it limits their access to the visual world and their ability to participate. So there's also a cause and effect relationship between advances in medicine and the incidence of CVI. In Israel, we see lots of kids with CVI, and those numbers are increasing, in part because children who in prior generations, infants would not have survived. The pregnancy would have not gone to full term. The child would have not survived other than very briefly. Now they're surviving, so we're having larger numbers of impaired children. There are other factors that feed into CVI. And when we talk about habilitation, we're presuming this is from birth, that they did not acquire visual skills, just to be really clear about this. And I was fascinated by this statement that cortical visual impairment is the most common cause of visual impairment in children in developed countries. Now, they also talk about the torch infections, and I was not familiar with that term, but I'm familiar, as we all are, with those causes. So again, these are things that now are impacting children as we get resistance to vaccination for whatever reason. We are seeing an uptick in rubella. When we don't have good diagnosis and treatment early on, we're going to get things passed to the baby in utero. These factors all can cause congenital cataracts and are considered a significant cause of CVI. Do I have something that's showing up here I'm trying to eliminate? Or are you just seeing my screen, or are you seeing other stuff?
Green.
Okay,
We're seeing your screen.
good, because I've got other stuff popping up here. Okay. So CVI is causing coloboma. It can be associated with, not causing, coloboma, nystagmus, and there's a question in my mind based on the kids I'm seeing. Is the nystagmus caused by the CVI, or is the CVI caused by the nystagmus? Most ophthalmologists here seem to feel that the nystagmus is preventing the development of vision. If only we could do something about it, the children would develop normal vision. I'm not so sure about that. Now, characteristics that are typical in kids with CVI. They seem to have a strong color preference. Sometimes they gravitate towards a particular color. Less often is it mentioned that there's avoidance, and this doesn't seem related to color vision deficits. They have a tremendous need for movement. They either need objects moving or they need to be moving in order to see. There's a big visual latency, so that you can attempt to direct a child's attention towards a significant object that's right there in front of them, and a minute later, they can end up shifting their attention towards the object. They show a strong visual field preference, and they have difficulties with visual complexity. all of these things are also characteristics of kids on the spectrum. Funny thing about that. These kids have a need for light. They have a specific level of light that they like and they want. Interestingly, they've been found, and this is based on studies with a couple of thousand kids, that they have difficulty with distance viewing. They may have a particular distance at which they attend, not closer and not further. They may have atypical visual reflexes to an approaching object. They may attend to objects with visual familiarity and have difficulty with visual novelty. And there's an absence of visually guided reaching in infants with CVI. And I was interested to note that many sources refer to dorsal and ventral streams, and that's about as complex as they get with this. But at least they've got the concepts that there are multiple pathways to vision. It's not all about the connection of the optic nerve to the visual cortex. So this is one of the tables, and this is used in a lot of materials by teachers to understand behavioral characteristics of vision. And they can use this to differentiate, is it a visual problem versus some other behavioral problem? My opinion, if you have a child who has a problem, it can be caused by any one of a number of things, because a child will react with avoidance for any one of a number of reasons. We can't oversimplify quite this much, but at least we're seeing awareness of visual behaviors or visually guided behaviors. And this really impressed me because I found a lot of different references to this type of a pattern. That children with CVI behave like they are highly nearsighted. I'm sure every single one of us has seen multiple children who may not be literate, who get their face up close like this and are wearing lenses for very high myopia when they come into the office. I know this is something that my father discussed with me 50, 60 years ago. So this is something we've all been aware of, and we didn't have good reasons for it then. Dad never had good reasons for it. But I find it very interesting and important that this is being observed consistently now in classrooms and being attributable to CVI. And they're looking at this a vision problem that's driving the myopia that's very different from the simpler or more traditional descriptions of accommodative convergence disorders, parasympathetic overstimulation. All those factors may be there, but the behavior itself can be driving it. And these, my clinical pearl sign, of course, is a sign. Very important. We've all seen this in our office. We need to point it out to teachers in school that a lot of kids who are labeled ADHD, they have to move to C. These children can act like something isn't there, and it's not a behavioral phenomenon directed at the person they are with. It's not bad behavior. It's a problem with the neurological organization of vision. And very significantly, that these children can act like they're very nearsighted. They may not be nearsighted at all, but more than likely, someone will make them nearsighted if it isn't anyone in that room or our colleagues professionally, because an average eye doctor is going to look at that child and start throwing minus on. And when they come back in 6 months, more or less, they're going to add more minus until we create even more vision problems. But the way it's being looked at in neuropsychology is bringing these things closer, eliminates background, and simplifies the complexity of the array. And again, the more I learned, the more I realized these can be very mild cases of CVI. And I believe amblyopia falls into that category, although people here disagree with me. But it makes me question the relationship to high myopia. So they're talking about visual field issues related to CVI. And the reason I bring it up is because having looked at the research that I could, they're just doing a form of confrontation fields. So to me, this is too vague. Confrontation fields on a child are not going to be particularly accurate or meaningful. So there might be a higher prevalence of inferior field loss. There may not be. These kids may simply not know where their feet are or where the ground is. So they've got all kinds of recommended assessments. And I'm going to show you that chart in 2 parts because it's a lot easier to see. And in what they were doing, they mark whether it's assessed, not assessed. And this is how they did things in a particularly large study, so that they could differentiate between cortical visual impairment and ocular impairments, or a combination of them. And this is another type of an assessment chart that they use. And they can put it together something like this. All of this is in that book if you want to look it up, because it was, like I said, very interesting, very quick read. So here's what we know. According to neuropsychologists working with visually impaired kids, the higher functioning they are in terms of CVI, meaning less visual impairment, the better the kids function. Well, that's interesting. I'm really glad they did research to tell me that. Interventions are indeed possible to improve vision in these kids. The interventions have to be driven by the kids' needs, not by what are the materials we happen to have available to work with. We need to set up a program that addresses where that child is, what they can do, what they can't do, and how do we get them functioning in a classroom type environment. So now this is really the more important part of anything I have to say, which is what are we going to do about it? So I am working here with kids, many of whom have been diagnosed with cortical visual impairment, many of whom are legally blind, many of whom have multiple handicaps and are nonverbal. And because I have limited interaction, I'm going into the schools, doing evaluations on kids, and then I have to teach the teachers what to do, because obviously me showing up once in a while isn't going to be good enough to do much of anything. So that the schools have to buy materials. We need to give things to the parents to work on at home. And I've developed a few techniques that I think can be used even with kids who are just plain younger patients, to start engaging them visually with their visual world. So working with balloons, I'm sure most of you don't have a helium tank in your office, but I'm going to suggest if you're working with severely and visually impaired kids or adults, get a helium tank. They're cheap. You can get them any party supply store. Because if you set inflated balloons around the room with a weight on them, you've now created a very interesting visual environment with very obvious big targets for them to start learning where things are in their spatial world. You can get little lights to put inside a balloon so you can light them up. Great technique, works really wonderful. So now you have the child walking around in a room. They've got to find and touch each one of the balloons. Or say you have balloons in two colors. We'll just say red and green because that's what I would say. Can they find each of the red balloons? Can they find each of the blue balloons, green balloons? They have to walk up to it and they have to touch it. Make a note of their search pattern. Are they only looking to one side? Do they repeat? Do they have a color preference? If you have, say, 4 different colors, 2 balloons of each one. What happens if we write numbers on the balloons? Can they find the numbers in order and ignore the colors? So, what about floors? People working with visually impaired kids are saying, oh, these kids have an inferior field loss, do they? Maybe they have an inferior field neglect. Maybe they don't really know where the floor is. We've all worked with things like this. So these are some very simple techniques to help children find their feet and find where the floor is. So you can put brightly colored targets on the floor. Now, in environments where we're working with severely visually impaired kids, you don't want to do that. We want a plain light colored floor so any obstacle stands out. But in a therapeutic environment, maybe you do. Maybe you want to get some bright colored duct tape and have the child following the tape around the room or across the room. So we can use flashlights. I don't like giving young children lasers because we've got a 90% likelihood they're going to flash it in their eyes or my eyes. And while it's not likely to do any damage, I don't like it. It's not nice. So I use tactical flashlights, which are equally unpleasant if they're right in your face, but the child's less likely to do that. You can buy on Amazon paired red and green tactical flashlights. If you don't know what they are, they have a condensing beam. So it's a very intense, bright, square target across a room. Whereas a normal flashlight, you have to be very, very close to see the color and the shape of the light. So can the child aim the light at targets that are on a wall in front of them? Or how about on the floor? Can an older child use a laser? And I do use lasers with older children and with adults. And you start out with things that, of course, the child can localize. Whether they can identify them or not is another story. Maybe it's just a great big black square. Can they find it? How many of them can they find if they're on the wall or on the floor? And we work towards smaller targets. And I've got a few videos to show you some things that I do. And if the sound doesn't come up, it doesn't really matter. So I throw things together when I need to. This is stuff that came from a store, the equivalent of Five Below. So we've got these colored popsicle sticks I glued into a plastic, fairly flat plastic bin. And you can see up in the top right corner, I've got a little plastic ball with a bright light in it. The light is critical because you can work in a somewhat dimmer environment and the light is more likely to attract the child's attention. And this does work with adults who are visually impaired as well as children.
I want you to
can you hear it?
move the ball to the other side. Good. Now back next way. Good. Keep going. Good. Now I want you to go back again.
And we're hearing it just fine, Marsha.
Good. Now, we can change that as it gets easier and go from a light to a ping pong ball. So now the child has already learned some visual attention to the task. And then
Okay,
we
we
make
have,
the
wait, we
balls
have
colored.
3 balls. Which color do you want to use? Okay. Now watch it go. Now we're going to try something else. Tip it like this. And you're going to tip it the other way and tell me which ball gets there first.
This one.
Okay, now
Which obviously it wasn't. But it gets them to pay attention to more than one thing.
okay, we have, wait, we have 3
I'm
balls.
going to
Which
show you a
color
few
do
of
you
her
want to
trials
use?
here.
Okay, now watch it go. Now we're going to try something else. Tip it like this. And you're going to tip it the other way and tell me which ball gets there first.
This one.
Okay, now go back the other way. Which one got there first?
Blue.
Okay, so the first trial, when she thought it was the green, that's where she was looking. So that's what she saw. The next trial, she was actually looking at all 3 or attending to all 3 balls. I'm a huge fan of light up glow rings. They are great for getting kids to know where their hands are. I use them with adults also. They have to know where their hands are if they're going to develop some visually guided motor skills. These balls, these rings I got on AliExpress, and they're getting harder and harder to find. I went to more stores than I could tell you, couldn't find them, finally ordered them. They actually have multiple speeds. So when you first squeeze them to get them to light, they go very, very fast. Then you squeeze them a second time, not quite as fast. And then the third is slow. So you can see one is a whitish, it's actually clear, while the other ring is blue. And there are the lights in them flash and change at depending what speed you want it at.
Okay, these,
Now, again, they have to know where their hands are.
when I tell you to, you're going to roll them away and back. Nope, straight in front of you, not like that. And we're going, nope, together. And you're going to count to 10. Okay, ready? Okay, go.
1, 2, 3, 4, 5, 6, 7, 8, 9.
Good. Now they take turns. One hand goes in the front and one back like that. Good. Do it and
What?
count. Keep going.
7, 8, 9, 10, 11.
We talked yesterday about integrating techniques. You put the flashing rings on their hands if they can't keep their hands and the balls together, or you use the little clear balls with the ring, with the lights in them. And I'll show you where to get those if you're not familiar with it. They also have to know where their feet are.
When I tell you to start, you're going to move your feet together, forward and back while you count to 10. Okay, ready? Go.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Okay, now they're going to take turns. So one foot goes in front and one goes in back while you count to 10.
7, 8, 10.
Now, I've recently starting doing more with music to help them follow rhythm. If the child can't follow the rhythm in the music, I use a metronome app on my phone. So I work with color awareness. First thing when we're dealing with vision habilitation is motion. You have to start with moving targets so that you can get the child to pay attention to the target. That is the best thing to do. It's the best place to start. When we start moving with color awareness, we always start with recognizing and labeling red and then work from there. Then we give them a choice of two colors. Can they match them? And we then move on to labeling. So I start with a very simple color matching chart like this, and I'll use paper to cover all but, say, for instance, the red and the yellow. And can they consistently match them? Good. Now we're going to add 3, the red, the yellow, and the purple. Now we'll go to 4 to 6, and we end up building a very complex chart. And I use hanging balls working with kids. This is a child who could not reach, could not grasp. Well, it can now. And this is how we did it. So we encourage motor responses. We've got to have an appealing target, and it's got to be something that attracts their visual attention. A moving light does that. And these are little plastic balls, and you put individual lights in them. Young children can't get those open. The lights themselves are small enough to swallow, the balls aren't. If you want to work with a whole classroom, if you want to work in a bigger space, these are much larger, and you can control the colors. So you can position them around the room and find the red ones, find the blue ones, and so on. And you can shift it because they are remote controlled. And this young lady is playing with them. She wanted to put some of them in and out, and she was being supervised by her teacher. And she is quite visually impaired and doing extremely well with her visual attention. You can also get different colors of lights for those mini lights. You can't get them that they switch color, although you can get one that flashes that just keeps flipping through these colors, but you can't get what you can get with the slightly larger ones, so that you can work with manipulating these balls, matching and separating, working with colored light, which is much easier than the color chart. And of course, one of my favorite things to use with patients who are severely visually impaired, head-mounted laser. And we all know different activities we can do with this, but this gives you a lot of things that do work with severely impaired kids. It also works with adults with vision rehabilitation, including people with cortical blindness. This is where you start. And this is where I end.
Thank you, Marsha.